Welcome, everybody. This is, I believe I was told, our last live training on accessibility strategies. So we'll have a few more trainings coming forward that are recorded, but this is our last live one. So thank you so much for being a part of this learning process with us. We've really appreciated having you on board as we're working to make sure all of our mobile crisis teams have what they need to provide services for their counties. So today, like I said, we're going to talk about accessibility strategies. We're going to focus on a few specific types of accessibility strategies. But before we do, the disclaimer is that this presentation was prepared for the Medi-Cal Mobile Crisis Training and Technical Assistance Center project. This is funded by the California Department of Healthcare Services and administered by the Center for Applied Research Solutions. All the material appearing in this presentation, except that taken directly from copyrighted sources, is in the public domain and may be reproduced or copied without permission from DHCS or the authors. Citation of the source is appreciated. Do not reproduce or distribute this presentation for a fee without specific written authorization from MTech Project. Again, these trainings are part of the new direction from mobile crisis services being offered through the state. The change mobile crisis services so that the response is more resolution focused and it works to provide relief to people in crisis in the community. It's supporting people in crisis where they are, meaning that we're using the least restrictive means necessary. And that's the intention of this benefit. Mobile crisis services are designed to provide rapid response, individual assessment, and community-based stabilization to Medi-Cal members who are experiencing a behavioral health crisis. Our services are designed to provide relief to members who are having a behavioral health crisis, including use of de-escalation and stabilization techniques to reduce the immediate risk of danger and subsequent harm and avoid unnecessary emergency department care, psychiatric inpatient hospitalizations, and law enforcement involvement. Our mobile crisis direction is person-centered, trauma-informed, equity-driven. We're really incorporating brief intervention, so de-escalation and resolution-focused strategies. We're working from a lens of least restrictive interventions and being culturally responsive, linguistically appropriate, and accessible, which that last point there is what we're really going to be focusing on today. So I'm hoping to tap into the collective expertise of everybody on the call as well. You may have ideas that can really help people in other counties, and we really encourage you to share. My name is Jennifer Hodson. I work with Health Management Associates, which is a consulting firm, but my background is largely in behavioral health. I taught at a university for the past 22 years before joining HMA, taught in a master's program in marriage and family therapy, directed a doctoral program in family therapy. So my heart beats strong for finding ways to provide services to people where they need it the most. Have done some work with crisis lines specifically, and then helping different systems, whether it's school-based, primary care, other based settings, to really develop crisis protocols. So these topics are really important to me, and I'm really honored to be able to be here with you today. This is our agenda for today. So we'll go gently through just some tenets of the BIN 2325 to talk about the accessibility services requirements. So I'll just reference different parts of the BIN, and then if you wanted to go back in and read more, you can. We'll start off with talking about individual disabilities and what they are and some strategies. We'll focus in then on people who identify as hard of hearing and what that means and what we can do through this benefit to be able to provide the best services and supports to those who may need some additional accessibility support around that. We'll also talk about some of our people who are in crisis who may have visual impairments, and what are some of the adaptations and accessibility strategies we can use when we're providing services in the field as well. We will, end with some additional strategies in working with the nonverbal community. So there's just going to be a little bit of slides around there. So you may have opportunities when you're going out to provide services with people who are nonverbal, and what are some of the things that we can do to be able to support them in resolving their crisis. as well as people who have limited English proficiency, which in California, we have a large volume of languages that are spoken in the state. And so, how do we, provide accessibility strategies in a way that allows people to be able to use their preferred language, which is often deeply, deeply connected to their emotional expression so that they can get the best care and services that they need. So we'll talk about some of those aspects as well. And then at the end, some Q&A if you have some additional questions, anything that we don't have the answers for today, we can certainly post and get back to you about as well. So sometimes we'll have really good questions that we need to think deeper about than just this moment, and we're able to provide responses back to you if that's needed. Okay, so some of the learning objectives are to address the accessibility service requirements as described in BIN 2325. The slide deck, there's links throughout so that when you get the slide deck, you can go ahead and, connect to some of these things. So if you see anything highlighted with blue underline, know that you can connect right through to the source. We'll understand the impact of invisible disabilities and accessibility needs, communication strategies, adaptive equipment, and other accommodation supports for our mobile crisis teams, particularly those working with individuals with hearing and visual impairments. Identify best practices for using interpreters during mobile crisis services. We have provided a lot through MTAG. We've provided a lot of previous trainings that some of the curriculum we're going to be talking about today builds off of. That's why we call them our building blocks. So this is a long list of trainings that you can go back to if you wanted to go a little deeper in with a specific population, whether they're children, whether they're adults. We have some real great trainings in here that can help you to really build out a robust accessibility plan. And then there's one additional training that we're going to be recording coming up on verification, eligibility verification, documentation, and access to services. That could also be a good training that would help deepen some of the material from today. So just to kind of briefly go through some of the BIN related accessibility service requirements. The first one involves the use of telehealth. So telehealth provides us with a really great opportunity for engaging people that we're serving in our communities with a different accessibility services. So we may not have somebody on the mobile crisis team who may speak the language of the person that we're providing services to, but we can engage through telehealth somebody so that we can make sure that we're addressing the needs of that individual, whether it's American Sign Language or another language other than the ones that our team members might speak fluently. So just to know with that telehealth benefit, that's definitely a strategy that some of our counties are able to use so they can bring those accessibility supports into that encounter. The other aspect of the BIN is that you're going to see there's a lot of reference back to different BINs, different DMH information notices. So the BIN provided you with this information and linked to those documents. I went ahead and just incorporated that into this training. We're just really encouraging the counties to go ahead and review those to make sure that the policies and the practices that you're developing around accessibility are meeting the full requirements from the benefit and the other notices that have been attached to it. And that those should be reflected in your implementation plans. Don't think it'll be anything largely surprising, but we just really encourage people to make sure when you're going through that you're also reviewing those as well. And then a few things, as many of you have been working with your implementation plans, is just to make sure that in there are mechanisms written to ensure culturally responsive and accessibility care. So what one county's plan might look like may be very different than another's because of the types of access to supports and services they have or the populations that they're serving. So it may be a little different across different counties, and it will be, but just having that addressed in your plan is going to be one of the requirements. And then how you're going to outreach to advise Medi-Cal members on the availability of those services and how to access it. So if you have a large population of people that happen to speak a language other than English and Spanish, let's say, how are you going to be able to reach out to that community or population and let them know we can still provide services and care for you through this as well? And then all the community partners and stakeholders that they're also aware that you're going to be able to meet those needs. So, as I had said earlier, we're going to start talking a little bit about the idea of invisible disabilities. So, some of you may have heard this terminology before, and some of you may not. So, we're going to actually have an opportunity to interact about this. But in general, individual disabilities are those hidden or unseen disabilities or conditions that affect an individual's daily life and are not readily apparent to other people. So oftentimes these can go unnoticed at first glance when the person in question has not made their difficulties known. And about 80% of people with disabilities have invisible disabilities. So if you can do me a favor in the chat, just to kind of get your juices flowing and for me as well, what are some examples of invisible disabilities that you can think of that you may work with in the field? Right. So I'm going to go through learning disabilities. Right. Many autoimmune disorders, and that people who struggle with autoimmune disorders may have pain, right? Um, need different types of stimulation to be able to get their needs met. So it could be medical issues that aren't met right. So if somebody's struggling with a cancer diagnosis or even a visual impairment, hard of hearing, you wouldn't necessarily know by first glance, or perhaps somebody who may have a developmental disability. We wouldn't know somebody who may have dementia by just looking at somebody you wouldn't necessarily know. So there's lots of people that walk around among us. TBIs, traumatic brain injuries, absolutely neurotypical. Yep. Autism spectrum disorder, right? TBIs, ID, right? General mental health issues, absolutely. Cognitive delays, reading disabilities, chronic pain, right? Absolutely. Homelessness, very good. So you don't necessarily know by looking at somebody that they're struggling with substance use disorders, like all of these things could be invisible to the work that we're doing, which is why when we're working on being able to do really good, joining in connection with people and finding really important ways to connect with them, then oftentimes people will share. When going through the assessment part of our work, people may not necessarily share things right up front, or that's maybe where it comes obvious. It may not be till some of these things come out until they really feel safe with the care team that's there with them. And then they may disclose some additional challenges. So some of this we may be able to find out during the dispatch process. Some of it we'll find out when we're in the field, and we'll pivot accordingly. So some strategies for supporting people with invisible disabilities, and these are just a few, but the first thing is to ask, do you need anything in particular for our visit today to be the most helpful to you? I don't know how many times I've walked in to work with somebody and they made recommendations like it's easier for me if you sit closer, or if you sit farther away, or if you speak, to this side of me because I hear a little bit better. Um, or it's easier for me right now with some back pain that I have if I can lay down. So everybody is going to have different asks of us so that they can be the most comfortable. And if we can accommodate that, we try and we will. If we can't, then either consulting, with our supervisor, or trying to figure out what's something that we can do to be able to help this individual, because this is the most pressing need for them. But the critical piece of this is having them to define that. The goal is to build a climate of trust so that people can and feel comfortable expressing their needs. They may not have had very many people in their lives who believe them, particularly people who have invisible disabilities. Sometimes people don't believe that they're having pain. They don't believe that they have autoimmune conditions. They're not, when I think about for years, like fibromyalgia, we worked with people in primary care. They would oftentimes have healthcare providers who would tell them that that's not a real diagnosis. right? So they're so used to being dismissed that trusting people is a very difficult thing to do. So that's going to take some time. To not assume that the individual does not have a disability. So when we walk in to work with somebody, asking everybody, is there anything I can do to make this visit the best for experience for you? That way we're not assuming that somebody has or does not have a disability. It gives them the opportunity through that open-ended question to share. To not assume that observations that we might notice, like slurred speech, imbalance issues, shaking, are signs of a substance use disorder. In the chat, what are some illnesses that slurred speech, imbalance, like difficulty balancing, shaking can be signs of? What are some additional things? Huntington's, a stroke, right? Parkinson's, neuro issues, absolutely. I actually work with a Parkinson's support group out here in North Carolina where I'm at, and we have cards that some of our members will carry around so that when they go to check out at grocery stores or if they're stopped by law enforcement for whatever reason, they can show them the card and it says, I'm not intoxicated. I have Parkinson's disease because they've had so many issues with that. So it is something that we oftentimes, when we look at it, we think one thing and it could be something very different. So that's why it's good. Bell's palsy. Absolutely. Thank you, Jackie. Paying attention to nonverbal cues, squinting, kind of cupping the hand over the ear to hear. So these are just generally nonverbal things that we might be able to pay attention to and then ask some general questions about. Or is it easier if I move it a little closer or if I sit more to the side over here? So those are just some things that we can teach our teams to look for. Try to face the person as much as you can when you're speaking and listening. Even if you have an interpreter there, we want to look directly at the person that we're assisting. Some of our people that we're working with will be able to lip read, so that's why it's really important that we face them. There's always the direction of sound too, that it flows a little bit better when there's not a path of resistance, right? So if we can sit facing somebody, try to get as much as we can at eye level with them because that'll also shorten the distance between sound. So these are just some of the things that we try to do to make sure we're creating an accessible environment. If you don't understand what an individual is saying, we just recommend politely asking them to repeat themselves or explain what they just shared so you can better understand. If somebody doesn't understand you, again, volunteer to repeat it again. Try a different strategy. If, saying it, you can try writing it down. Sometimes dialects are different, sometimes different hear a register of hearing. So we can hear lower voices easier or higher voices. So some words may be difficult. Also, when we're really stressed and we're in a stress response state, slowing down and sort of thinking about what we're hearing can be more difficult. So I think about just what think of an experience where you've been super stressed and you're trying to communicate something or listen to directions. So that can be why preparing our team that it might not be because they're having difficulty understanding us because we have a different dialect or accent. It just might be also the trauma or stress response. And so slowing things down just helps anyway. Breaking down complex information or instructions into smaller parts. So being able to, we have a technique we use with couples counseling where we'll say like 1 to 3 sentences most, and then have the partner repeat back because they've done studies. So if we layer questions or we put a whole string of thoughts together, especially when you're dealing with somebody who's really stressed, it can be difficult for them to track. So just, trying to give them a little bit of a time can be helpful. And then the other is to just listen and ask follow-up questions respectfully. So, eh, you know, to deepen our understanding of what the concerns are, if they use a word, you say you're stressed, can you tell me a little bit more about why you're stressed? Or you say that, you're done. Can you tell me a little bit more about what done means to you? So just learning how to take words and then continue the thread of the conversation from the person we're caring for's perspective, even though in the back of our mind we're thinking of a lot of other questions we need to know and ask about. That's part of joining and opening up that accessibility space where they're feeling heard and listened to, and then we're able to make sure we're setting up that experience in a person-centered way. Are there other strategies that you think of that can help support people with invisible disabilities? Anything else that you all can think of? Please put it in the chat, because like I said, these trainings are only as rich and robust as all of you are able to sort of put in your experiences as well. Share a template for that card. Yes, I can absolutely try to find that. And if Andrew can flag that for me, he's one of our team members, I can look that up. That was very, very helpful, and very empowering for my members to carry that card with them. So definitely can. You're welcome. So if you think of any other strategies that sort of help for people with invisible disabilities, feel free to put them in the chat. Oh, we also laminate small wallet-sized cards they make for them to look at when they need um, some extra help. Right. So it could be, if somebody does, we've had patients come into primary care where they're carrying a little card that says, you know, um, I am having trouble hearing out of my left ear. Can you speak more to my right? So sometimes people will have these laminated cards with them because it allows them to drive it, and their caregivers give them more, as independence and autonomy as possible by being able to communicate what those needs are. Very good. Okay. So, what does it mean to be hard of hearing? And I really want to say there are language and terminology evolutions that happen with all different disabilities. So, it is important that as we're learning things, like as I was even preparing for this talk, there are definitely groups of people who don't like the terminology hearing impairment, but there are groups of people that prefer visual impairment or hearing impairment. So it's really about being person centered and finding out what are that community or what that individual likes to be referenced to if it comes up. So I just try to always use the language of the people that I'm taking care of or working with so that I'm meeting them where they're at. So if there are languaging or phrasing in here that you need to adapt and change, then I really, really encourage that. According to the National Deaf Center, the deaf community includes people who identify as hard of hearing, late deafened, deaf, deaf blind, deaf disabled, and then there's others. So there's lots of variance within that hard of hearing community that we want to be aware of, because they're all going to have different types of needs and requests to be able to have access to services. Some experiences are shared across all of the different variants, and some are very unique. So obviously we want to lean into what exactly does this person need, and then what can we provide for it, because not all people will need the same thing. A sound amplifier may not be as helpful to one person as somebody else. Most people who are hard of hearing, they can perceive sounds, but they may have experienced difficulties in following a conversation. So it might be they could pick up certain words, or between the lip reading and the sound, they can put things together. But they may be missing some pieces. So that's where stopping and repeating back what you're hearing, or giving them the opportunity to do that, can be very helpful to make sure that the tracking is happening on both sides. We know that loss of hearing ranges again from mild to profound. So it could be something, that is, happens with certain ranges, like I was saying before, or it could have to do with environment. So if you're in, some of the work we do may be, in open spaces. So if there's construction work happening or there's a lot of loud sounds, it may make it difficult for somebody who normally would have a very mild. It may be something that's more significantly an issue. People who are completely deaf, they actually represent a minority of the hard of hearing population. And a person who is deaf is not necessarily non-speaking, just as a non-speaking person is not necessarily deaf. So we also need to be adaptable to know that it could be, that they're able to speak. They just need the ASL interpreter to be able to let them know what you've said, but then they may choose to speak back. So to be prepared for a variety of experiences is good. And then there are a range of abilities and preferences related to people who are hard of hearing. Even people who do not have a diagnosable hearing loss might struggle. So think to times where you may have had a really bad cold, or like I said, there's an environmental issue where it's difficult to hear. There's lots of things going on around you. So you might have to turn up the volume on your speaker on your phone, or ask somebody if they could speak a little louder because like, I think of restaurants, right, where there's tons of conversations happening and it could be hard. So even people who may not identify as somebody who has, challenges with hearing, we can understand that it could be different from one time to the next for somebody. The prevalence of hearing conditions. So, nationally, according to the Center for Disease Control and Prevention and Hearing Loss Association of America, there's about 48 million, or 14% of Americans have some degree of hearing loss, which they say is about 1 out of every 5 men and 1 out of every 8 women have some difficulty. Hearing loss is twice as common as diabetes or cancer. So, it's actually a more common incident to find somebody who's having, some hearing loss than it is to find somebody who's diagnosed with diabetes or cancer. The National Institute on Deafness and Other Communication Disorders reports age is the strongest predictor of hearing loss among adults. So as we age, we do tend to have some challenges as we move through life. That's why 91% of adults over the age of 50 have some aspects of hearing loss. Approximately 3 out of every 1,000 children in the US are born with a detectable hearing loss in one or both ears. So, if you've ever had the opportunity to be in the hospital after a child's born, they have that hearing test that they have to pass before they're discharged, right? And that we can tell at a very, very young age if there's an issue and then do some early intervention. 15% of school age children, which is the ages of 6 to 19, and about 20% of teenagers have some degree of hearing loss, which is pretty significant. So that's why we don't want to just prepare our teams to ask the questions for older adults, but for everybody. And we have 13% of adults 18 and older have some difficulty hearing even when they're using like a hearing aid. And about 1.6 either have a lot of difficulty hearing or couldn't hear at all, even when using a hearing aid. So, not all hearing aids are equal or of the same sophistication. So, it could be that they're having trouble because of the quality of the hearing aid. Maybe the battery is running low. Could just be that the hearing aid's just maxed out for the environment that it's asked to operate in. Non-Hispanic white adults aged 45 to 64 had higher rates of difficulty hearing or being unable to hear at all compared to other races. And in 2019, 7.1% of adults aged 45 and older use a hearing aid. Use was higher among men than women in all age groups. So while hearing loss can occur at any age, prevalence increases with age and has been shown also to be associated with cognitive and functional decline in older adults. So we're seeing, like you may have heard recently, there's a lot of research coming out where dementia and hearing loss are correlated. So as we age and as hearing loss occurs, can imagine it becomes pretty frustrating for people when they can't hear and they can't communicate the way that they used to been able to. It can really take its toll on mental health and functional decline. So really trying to align people with resources that not only help their crisis that they're in, but maybe potentially some of the reasons why they might have exacerbations in their mental health. According to the, and I'm going to go back, Hearing Loss Association of America, so I didn't want to misspeak that. On the job exposure is particularly common among US veterans who can access VA services for hearing aids. So people who have served may have had hearing loss due to when they were in combat or even just going through training. There may have been incidences where they had an explosion or a loud noise and it destroyed some of the nerve endings and their ability to hear. So we're seeing it's pretty common that we want to assess for it and we want to try to pair our veterans up with resources. So hearing loss and or tinnitus are the most common service connected disabilities among our US veterans. And tinnitus is that ringing in the ear that people hear and then it's hard to hear past that. And for some people, again, higher or lower can happen more certain times of the day. 2.7 million veterans receive hearing care or are diagnosed with a disability related to hearing loss. It's a lot. And about half of all blast injuries experienced by veterans resulted in permanent hearing loss. This is just some hearing disability prevalence data. So if the United States is about 3.5% on average, I just wanted you to see some of the counties in in California where they fall out. Fresno's like right about at where the United States in general is. So I just show this to say maybe looking at the data in your county and getting a really good sense of prevalence. Also, there may be certain neighborhoods or areas or communities. Maybe there's some senior living settings, some schools for the deaf, hard of hearing, places where we really want to be able to make sure if we're going to be going, that we're taking the adequate resources that we might need to be able to provide the best service possible. Again, impacts of hearing loss on mental health. We know hearing loss can make it very difficult to interact with peers. It can lead to decreases in social engagement, depression, mood disturbances. Again, largely connected to depression in older adults. Untreated hearing loss can contribute to increased mortality, higher healthcare spending, impaired communication and social interactions, which can lead to social isolation and psychological distress, and again, depression. So, over and over, we're seeing in the research that hearing loss is closely connected to a lot of mental health challenges. Regular hearing aid use has been associated with lower prevalence, but not everybody can afford access to hearing aids or afford access to the right sized hearing aids or the highest a level of technology they need. So that's also a challenge. Some studies have shown that reductions in depressive symptoms within 3 months of hearing aid use. So figuring out how we can help align our populations with these resources is also a part that our teams might need to know about as well. There's some strategies for our mobile crisis teams working with our hard of hearing community. Mobile crisis dispatch, as you know, when they're doing their triage process, they're going to be asking people who call if there are any hearing accessibility needs or visual conditions that our team should be aware of so that we can provide the best care. So they're going to really try to get some of that information from the person calling so that we're prepared to either access it through telehealth or making sure that the smartphones that our teams are taking have the apps on them that they might need to provide services. Teams should have these apps installed and be practicing with them and interacting with them before they go out on some of these calls. Everything from sound amplifier apps to maybe an app on their phone where it's like a magnifying glass so it can show something, make it bigger for people. Sometimes it's adding light so that people can see a little bit easier. So flashlights or other, the flashlight on your phone or either a handheld. So there's lots of different like tools in the toolkit that we can give to our teams to help. And that they should be also obviously familiar with what interpreter services that your county has accessed and either contracted with, or if you have certain teams that can go out because you have people on those teams who may speak the preferred language of the person in crisis. So we want counties to be able to build those teams and those resources. And that's part of the benefit that the counties will be able to do that with the monies that they're getting. And then practice, 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 right? Some additional resources are email, live chat, text message. These are all options for communicating people with hearing loss. We want to try to be HIPAA compliant as much as possible. And in the moment, we just want to be able to deliver meaningful care and services. So if it comes down to we have to text back and forth with somebody because the app we wanted to use isn't functioning or the interpreter we weren't able to build the connection, keep them online with us. So we always want to have a backup that we can use and teach our teams to use. Again, we talked about speaking clearly and distinctly for people to read lips. If we do show videos, if there's ever an opportunity where we want to show somebody a video, making sure the subtitles or closed captions are turned on or a transcript's provided that they can read. So that if there are multiple people there and we're having them watch a video, some may need the transcript, some may not. So everybody can participate in that video that's being shown. Maybe it's a video about the Family Urgent Response System. Maybe it's a video about your regional centers. There may just be some things that you have. Maybe it's a video about diaphragmatic breathing. So whatever it is that you might want to show, that we're just able to adapt that. Using a common vocabulary so that the ASL interpreter is involved, they can easily translate what you're saying to that deaf member. So making sure that even the vocabulary we're using is something that the interpreter also understands and knows to use. And then ask if there's again, preferred ear or a specific distance that we need to sit so that we can improve communication. Audio induction loops or amplification systems can really help. These are some things that can be accessible through apps or other technology. Sometimes if the person we're going to support has, earbuds and they are accustomed to maybe using those and turning those up to amplify your voice. So there's different things that the deaf community may already be aware of, but they may not necessarily. So we want to at least make sure our teams are knowing and understanding how to use that technology. We tried to provide in here some commonly used apps. These are all free. Now there are, with most free things, they might also have like monthly rates that you can pay for an even better technology platform or additional services, or we tried to provide at least some foundational support. So there's something called Live Transcribe, Live Listen, Google Translate. Most of you might be familiar with some of these. So you can, like Live Listen's really neat. You could turn your iPhone into like a remote microphone that can be used with AirPods. And so these are just some of the devices like people may have with them that then could be used. They may not, but if they do, that can help. Tap SOS is really interesting. This allows people who are deaf or hard of hearing to connect with emergency services in a nonverbal way. So that's also available on the iPhones or Androids. And then again, the sound amplifier. Okay, so we're going to transition to what it means to provide support to somebody with a visual impairment. So we're transitioning a little bit from hard of hearing to visual impairment. Okay. Visual impairment can be any vision loss, whether it's somebody who can't see at all or somebody who has a partial vision loss. There's three categories that typically you'll hear about: low vision, so loss, they have some loss of visual acuity with a little bit of vision still able. There's legally blind. So these are people who have vision but less than the 2200. Visual impairment that might require special accommodations like readers, audio tape text, large print, magnifying glass, tape record conversations so that they can take notes. So there's lots of things. If we see students in schools use these resources, our people that we're serving in our communities may also need those resources. So just being prepared, like we can have some of these things with us, like the magnifying glasses or some of our materials, being able to make them available in large print if that individual needs. Some of our people that we're caring for may be totally blind, and so they might need braille, raised line drawings, again, audio recording. So if we're giving a handout on, we go back to like a grounding technique. Um, we want to also have that available on an audio recording. So we'll have it in written form, and then we can also have it in audio form. And there may be other like picture form. So we may even have people who would benefit from pictures. Um, so being able to adapt the type of materials that we're going to be able to provide to people to help respond to crisis so that they then develop some tools and strategies themselves that they can continue to use. When we look at national prevalence regarding visual impairments, there's about 6 million Americans have vision loss and 1 million have blindness. So more than 1.6 million are living with vision loss or blindness are younger than age 40. Over 350,000 people with vision loss or blindness are living in group quarters, such as nursing homes or prisons. 20% of all people older than 85 of age experience permanent 20% of all people older than 85 have experienced permanent vision loss, and more females than males experience permanent vision loss or blindness. So, and then there's a higher risk of vision loss among Hispanic, Latino, and Black individuals than among white individuals. Some of this may be to the lack of service access, early intervention. So, keeping in mind that this can also make their ability to navigate, stress and resources a lot difficult. And not everybody will say right up front that they're having trouble seeing or reading the text. So we just want to double check again. Are any of these resources that we're providing you today, would they be better in a different form? And that way we're giving everybody the chance to say what they might need different. Some impacts of visual impairment on mental health. We also, through studies, have seen depression and anxiety are elevated with people with visual impairments. So, this individuals of lower socioeconomic status are at increased risk for vision impairment and then subsequent mental health problems. Kind of touched on that a little bit earlier when I had said, early screening. And I'll tell you, we had a back to school event in our community. And so we were trying to do sports physicals. I don't know if that's something in California you need to do for the kids to participate in athletics, but I think it's pretty universal. Basic things they want to see: vision test. They check, different things like listening to the heart, just to make sure that the child is safe to participate. Well, we detected quite a few kids with undiagnosed vision issues from that particular screener. So a lot of our kids either are not able to getting access to well child checks or getting these vision tests, and then they're sort of pushing through the school system, not getting what they need. And then we know from there the increased level of frustration, anxiety is cumulative in that effect. So sometimes, like the root of some of these mental health concerns could be in vision and hearing. So that's why we always want to be thinking about access to resources in a wide variety of ways and for a wide variety of audiences. Existing psychosocial interventions for improving mental health in people with visual impairment show promise, but are limited in low adherence, and they lack generalizability to a wide variety of populations. So there's a lot of work basically that needs to be done in how to better engage people with visual impairment in psychosocial work. And then unseen messages like facial expressions, eye contact, gestures can also lead to confusion and cause anxiety. So much of our communication is nonverbal. And when we can't see, what expressions that person has, that can make it very difficult. I think about, we'll go back to Parkinson's disease. We talked about that earlier. One of the symptoms of Parkinson's is what we call the mask, where they basically lose the ability to make facial expressions, which then can make communication a little more challenging. So getting people to then be able to like let people know what they're thinking or feeling because their facial expressions are not consistent. But likewise, when we're trying to communicate with somebody, being mindful that there's a lot of messaging that comes with that. And for people who might be really upset, if we're not able to understand facial expressions or they're not able to understand or see ours, they might think we're not being empathic or listening or supportive. So we want to make sure we're sitting at the right distance and they can see as much as possible so that they can connect with us. Prevalence of vision difficulty in California. So I pulled some statistics just to show, and these are, you know, apt to change, but the one is from 2021, about 11.2%, or 4 million out of the 38 million individuals in all ages in California have one or more disabilities. And vision, as you can see, is about 2.2% in this. Hearing is 2.9. So we've got cognitive up at 4.7. Um, and it's significant enough to where we want to make sure, like, listen, we want everybody, no matter if it's one, to be able to get the support that they need. But recognizing where the incidence rate is in our different areas of California is going to be really important to be prepared. And then the chart on the left just shows a breakdown with vision difficulty, with in this one, more females than males demonstrating it. And then if you look at the age group, what's interesting, 35 to 64, for some reason, is where you're seeing a bump, and then 75 and older. So accessibility strategies for working with the communities where they're having challenges with visual impairment. Obviously, first is asking before offering help, you know, and if somebody says they're okay, they don't need it, that's all right. Some people have had really bad experiences with what a sighted person thinks is helpful. So not everybody needs to, hold our elbow. Not everybody needs to have us provide, different supports to them. They might want to do something their way. That is fine. We just want to be prepared to be flexible so that if somebody does say, I could really use that in another format, we're prepared for that, but not to assume that just because somebody has issues with their vision that they would prefer something be given to them on a hearing level versus a vision level. When people use a white cane or a service dog, it doesn't necessarily mean that they're completely or totally blind. So those are things that we also want to be mindful of as well. We want to be precise in giving directions and instructions. So instead of like pointing and saying it's down there on the right, which can come across as thoughtless, we want to make sure we're asking people what exactly they need to be able to identify whether it's an object that they're asking for, like, I think I dropped something. So we just want to be very thoughtful in the way that we're giving those instructions. When possible, if we have large print books, electronic visual aids, or any other devices, to have those present. Voice-based apps can also help as well. Using everyday descriptive. So I think sometimes people are hesitant to use language that they don't know if it will be okay. But what we're finding is, continue to use the words like look, see, read, knowing that people who are blind and have visual impairments have the same vocabulary so as people without. So you can still incorporate those words into your communication, just being very thoughtful and mindful about what you're using them for. We want to explain noises and silences and not shouting. So if somebody has a visual impairment, obviously we're not going to respond with more volume unless they are also communicating they're struggling with hearing impairment as well. And then if there are, sudden things that we're reacting to because we can hear something in the background, that we're explaining our changes. Don't be afraid to use physical touch if that is something that seems appropriate, but be sensitive to cultural differences. So not everybody, and being trauma informed in that, not everybody wants to be touched, likes to be touched. So even though you may have known somebody with a visual impairment that responded well to that, we want to make sure each person is individualized in what we're doing to kind of help them. Describe sudden changes again in the environment. So if you move or if somebody comes in or out of the room, that you're able to describe that and to let them know. I'm going to move to a different location so I can, sit down and pull this together that you might need for the next part of the work you're doing. But just explaining, or if they're walking from one place to another, you can just let them know, okay, we're going to go down the stairs now. So that just helps them to anticipate, lowers their stress and anxiety, and again, creates more independence and autonomy. Hey, this is the part where we're talking just a little bit about accessibility issues for our nonverbal members. Now, there's a lot more that we can do with this piece of it. So I just want to let you know we're sort of touching base on this, but if you have additional strategies for any of these groups that we're talking about, please feel free to put them or links into the chat. So, some accessibility strategies for working with community members who are nonverbal. When somebody cannot talk or will not talk, trying other things like, writing things down or pictures. If you have ability to show some pictures, there's some really great toolkits that are out there for working with people who are nonverbal. So they can have these already put together. So if you want to show a picture of a hospital, or you want to show a picture of a phone, or show a picture of breathing, you know, so maybe there's some ways that we can then use these picture cards to kind of help somebody um, be able to visualize a calming space, or being able to know what's going to happen next. Hand motions can be something else, eye contact, facial expressions. These are all things that are really important. When I was working with somebody who was nonverbal, we were trying to work with her. She was having a feeding um, issue. And so I was working with the nutritionist and her mom. And during the course of the meeting, the young woman was getting very agitated. She wasn't verbal, she wasn't able to verbally express what was going on, but she's getting very agitated. And her mom, so we were all talking in a group, and the mom said, do you mind when you ask questions looking at my daughter? She's feeling left out. So the mom was able to tell me, because I was talking to the mom and I was talking to the nutritionist, I wasn't talking to the daughter. That was challenging. Even the daughter couldn't verbally respond. She wanted that opportunity to be directed because she was the one who the appointment was for. So these are like the things that we can use family supports to kind of help us with, but being okay with getting feedback in the moment and then pivoting, so that, because we're humans and we might be looking, in a direction, and it's not our intention to be disrespectful, but it's being experienced that way. So we have to own that and then change what we're doing so that we're being more inclusive. So those are some things to just be prepared for. And I share that because we all have kind of had moments where we've realized, okay, I need to be more person centered in my approach. So introducing yourself, don't assume that somebody, again, can't hear or understand because they won't speak. So some people might have selective mutism. They might have severe social anxiety. So their nonverbal might not be because they can't, but just because that's how it's playing out in their current state. So they can still hear, they just might not be able to communicate back. Watch your tone. If you're speaking with a teen, speak as if you're talking with a teen and not a child. So I think that's sometimes setting for adolescents. They are at that really tough age between, being a child and being an adult. So that's a tough balance. And if you've known a teenager, you've known one teenager. They're just all different. So, but we want to try to speak to them um, is clearly and respectfully, and moving toward a more adult type level of conversation. Um, we want to reduce distractions. So having side conversations. So if somebody is nonverbal, again, I give that example from earlier, having too many conversations with our team member or somebody else who may be present who's not identified as the person in crisis, can be very distracting and upsetting. And then being aware of your physical presence. This is something that a colleague of mine, Josh Severns, had mentioned, um, because we might be very tall and very big in stature, and we're working with people who may be very differently sized than us, and that can be very intimidating. So knowing our size and knowing how that can be in a room or in a space of somebody who's different, and how do we manage that. I once supervised somebody who used to play professional football, and he was a center. So he's a pretty solid, big, guy. And when he would go into these spaces with people, he really tried to find a way to be as eye level as possible so that everybody felt, that they were safe and included and at that level. Even when working with children, I try to like get to eye level as much as possible. So I think just being aware of physical presence is going to be an important thing to be aware of. And we're all going to be different. Okay. And this is the last section is on working with our community with limited English proficiency, which I think most of our counties are troubleshooting, trying to figure out how do we meet all the needs of all the different languages that we're serving across our state. Um, Even the ones that are the most common to the least common, because we may get somebody who speaks Urdu, which is, a language that we may not have a lot of experience or exposure to, but are we able to secure a service that allows us to be able to speak that, um, so that the person can communicate in the language that they're able to in that moment or preferred. So, our limited English proficiency populations, according to the report by the World Health Organization, language barriers are constitute one of the most important factors that constricts access to mental health services, particularly for immigrants who lack proficiency in their host country language. So that if you can imagine nowadays with workforce shortages and other barriers to behavioral health care, limited English proficiency on top of that just feels insurmountable. That they'll be able to find somebody who can support them or help them or even communicate what they need. The pandemic and its social and economic repercussions have really contributed to increased stress and anxiety among people. Although all people are likely to be affected, our immigrant communities of color are especially vulnerable to the mental health fallout from the pandemic, and the need for more linguistically accessible mental health care. So, a population based study, even though this was out of Ontario, Canada, found that immigrant youth were more likely than non immigrant youth to seek emergency department services for a first mental health crisis without previous outpatient mental health care. So, more people will then utilize our emergency room system for that crisis support intervention because they're not aware of or don't believe they're going to be able to communicate with somebody prior to that. So, again, going back to what we said earlier, which is once we're able to get our mobile crisis services up and running, or if they already are, is letting all the stakeholders know we can accommodate a wide variety of languages because of these contracts and resources that we have. In the absence of bilingual and bicultural mental health providers or interpreters, are considered the most important resource to overcome language barriers. More important than ad hoc interpreters, which are untrained volunteers, friends, and family. So, really having professional interpreters is a critical. And if you can have people who are also trained in mental health support, one of the things that years ago, we started introducing behavioral health services in our community. We're working with Promaturas, and they had not had a lot of background and experience in working with mental health needs in their communities. And so we really needed to slow down and provide that level of support. Like, what do you do when you're listening to somebody's trauma narrative? And this is somebody who lives in your community or who shares a similar background that you do, or you've not been trained to know what to do with a narrative like this. I mean, when we all got our training going through school, part of self care and understanding how do you deal with secondary trauma was something that we were trained to do. And so, for a lot of our interpreters, that don't have that training, you can imagine the level of challenge that it might be for them. So that's why it's really important that we provide, supportive services that have people as much as possible who are trained to be able to navigate what they're interpreting and the impact that it might have on themselves. A systematic review on the quality of mental health services for language limited English proficiency patients found that the use of professional versus ad hoc interpreters actually facilitated disclosure of sensitive material and improved their satisfaction. So when they had people who were trained to be interpreters, understood, mental health, issues and crises, and were not just friends and family. And we'll talk about that a little more in another slide. California is the leader in the percentage of the population who are non-English speaking. 45% of California inhabitants speak a language other than English in the home. So this is a large likelihood that we're going to have when we go out to provide care that we're going to need these interpreter services. Just as a breakdown of some of the more commonly languages in California, you may know this already. So English, Spanish, Chinese, Tagalog, which is a national language of the Philippines. So that was surprising to me. I didn't realize that. And you may have realized that that's like one of the top 5 languages in the state of California. Vietnamese and Korean, Armenian, Persian, and then there are others. So just to be prepared for some of the cultural needs of our groups, as well as some of the language needs of our groups. If you could just take a moment for people, just put in the chat, what do you think are the top 3 most commonly spoken languages in your county? Spanish, absolutely. Spanish. Vietnamese and Spanish, absolutely. And for some of you who may be working with Native American Indian reservations, you may also have some Native American languages too that are more common, particularly because of where your community's located. Okay, so Tagalog is ASL, so Farsi, Arabic, Hmong, yes. Yep. So being aware, you're doing such a great job, being aware of these needs in your communities and being prepared, and even having people come and do guest talks to your teams and explaining a little bit about the culture and the language and what would be most helpful to them, I think would be a really great resource, knowing that these are some of the more common community populations that you'll be serving. Very good. All right. And then according to the American with Disabilities Act, the ADA places responsibility for effective communication, including the use of interpreters, directly on the covered entities. So we cannot require a person in crisis to bring somebody to interpret. That is a responsibility that we need to take on. So all of our county mobile crisis services are those covered entities. If in an emergency, we can't get somebody, or our contracted interpreting service goes offline, then we can utilize somebody, adult, or a minor child who's accompanying that person. But in those situations, that has to be like the last resort. In situations where there's not an imminent threat, an adult accompanying somebody who uses a language other than English or sign language may be relied upon. So to facilitate when the individual requests it. So if you have a person in crisis who says, I don't want an interpreter, I have bad experience with that, I just want my friend to do it, and then it's an adult, then that's something that, according to the ADA, we can honor. If the accompanying adult also agrees. So it might be that the person in crisis wants them, but the person accompanying them may not be comfortable. So they need to be able to agree to, and then relying on the accompanying adult, that they're appropriate. We also want to be careful if we have a household where there's concerns about family violence. And if you have the adult interpreting for the person in crisis, that may actually be conflicted. So, a lot of it's going to be your gut too. Danielle, who's on the training, she's one of our CARS trainers. She always tells people, and she's very good at this, like, you all have to trust your gut. So if something's saying to you it's not safe and it doesn't feel right, then we're going to work a little harder to try to get another person in to do the interpreting. Some important things to remember again is that the BIN requires our mobile crisis services that you have interpreters and translators for members who may need American Sign Language or other interpreting translation services. Remember, translators do the writing, interpreters do the talking. So sometimes people get those confused. Phone interpreting is useful for offering support in some of the rare language where finding a translator or an interpreter is not possible, or is more difficult in the moment that we need it. Interpreters also help with understanding mannerisms, cultural practices, expectations, slang, body language. Sometimes interpreters don't interpret exactly what we're saying or what the other person's saying. And I know that that's a challenge that can happen. So some of it too is using your instincts that if you said something that was quite lengthy and they said something very short, or vice versa, if the person you're caring for said something very lengthy and the interpreter came back with something really brief, to be comfortable to say, is there anything more that was said? I want to make sure I don't miss anything. Okay, so and sometimes it might be that that distilled way of saying it worked, but we want to always make sure. The types of interpreted services are on site. So obviously, if you have a high Spanish speaking community and you want to try to hire people into your mobile crisis teams that are going to be able to be face to face, in person, bilingual, that is preferred. But over the phone and remote interpreting can also be a resource. It's less expensive than face to face, but I say that because the cost of not having somebody in person could be great too. So, you know, it's really important that we just try to do the very best we can. We also have more likely to have technological challenges. So, poor video connections, weak Wi Fi, again, missed nonverbal cues when it's going through another person. So, having that person to person experience is much preferred. There is a certification in California that people can get for interpreting. It is required for medical appointments. To be a California certified interpreter, a person must be at least 18 years old and possess applicable language skills. A qualified interpreter is someone who's considered competent to interpret in at least two languages after meeting that standard or criteria. This is also required for court as well, if you're a court interpreter. So just to know that if somebody is going to go into a medical context or appointment, that they do have people who are trained to be able to follow them into those environments to make sure that that level of service is where it needs to be to best address that person centered need. On-demand language assistance services, counties should identify companies to contract with that offer professionally trained on-site, over the phone, video remote, American Sign Language, real-time mental health interpreters. Counties under the benefit are responsible for the costs of interpretation services. There are vendors, but they'll charge for the service. I'm sure those of you know that. It could be that aligning with some of your stakeholders to find out who they're using could be a really good resource, because they may have had more luck with certain services that are prepared to better meet the needs in certain counties. All right, and please put in the chat if there's any language assistance services that you found to be more helpful, reputable, cost effective. Please share that with each other. So use the chat for that as well. If for some reason the member needs to interact with DHCS, they do have free language assistance services through DHCS. So this is available on the web, but I wanted to at least provide this information for you so that, while the counties need to be able to provide the interpreting services for the mobile crisis service, if there's ever a need for then the member to interact with DHCS, that is something that they will provide. Using family and friends for interpreting. So I talked about this in the previous slide, and I just want to kind of go back to this, but we really don't recommend children be used as healthcare interpreters. Again, sometimes if it's an urgent emergent situation, the ADA says, you need to absolutely, but we're really trying to not utilize children. Some of the content um, and some of the language that needs to be able to be communicated may or may not be suitable for children. Um, Families might have different boundaries, different ways in saying, well, in our family, we're pretty open, but we really try to protect children as much as we possibly can. And not put them in the position of the crisis unless they're the recipients of the service. So friends, relatives, or children, we really try not to be used to use for interpreters. The other issue is they can also make mistakes, which could lead to wrong diagnoses or other issues. So you might have a family member that's convinced this person has a diagnosis that they may not have, and they communicate that. People closely connected to the individual may not also be very good for interpreters, whether they're friends or neighbors, because you're putting them also in a very difficult position to have to share content that may be hard to share. So, and I go back to the promotores that I worked with before and the experiences that I had with them as well. So, just wanting to keep that in mind, that even though, we may have to at some points, we're really trying not to rely on those informal interpreting service supports because of the nature of those relationships, and trying to protect the boundaries and trying to protect um, individuals who aren't trained to necessarily deal with what they're hearing or being asked to communicate. Can you think of any additional challenges with having friends or family providing that interpreter support? Anything that we didn't talk about or say? If you have any other thoughts? And people did give language link and a local ASL interpretation services communique interpretation. Thank you, Daphne, for sharing that. Right. So please, if you do know of other services, please share them, because I think that would very much help people. Okay, so the last is just the summary. And I just kind of wanted to go through that. Our counties are required by the BIN to have mechanisms to ensure culturally responsive and accessible care, and to advise our Medi-Cal members on their availability of the service and how to access it. So we're required to be prepared to do that. When we're providing people with individual disabilities with the best possible outcome, it's critical that we provide that climate of trust so they can freely express their needs. That comes with our verbal and our nonverbal, and our preparedness and genuine effort to try. People are going to understand if it's not perfect, but if we're trying at least, that means more than not trying at all or asking. There's a whole range of abilities and preferences to related people who are hard of hearing, as well as visual impairments, nonverbal. So that's why being flexible is going to be so important. And there is a close connection between hearing and visual conditions that are untreated or undertreated in mental health outcomes. So that's why when we walk into these crises calls, to know that, we might not be dealing with obviously the root of the issue. So if there are other services that we could provide referrals for that would help, then that could be part of the resolution plan. Mobile crisis dispatch, again, will be asking about some of these things. It may be that you'll get a clue prior to going on the call, that there are some resources and supports that you'll need. It may not be until you get there. So that's why we all need to be trained on what's available and accessible to us. And then knowing how to use all those different apps that can help amplify sound, improve readability, are going to be important to know before we go out into the field. Again, always ask people before offering help, and don't be offended if it's refused. So, and in the absence of bilingual, bicultural mental health providers, professional interpreters are obviously the gold standard, particularly people who are trained to work with people who are having mental health crises. There's a large variety of types of interpreter services, again, in person, over the phone, virtual. So we do as best as we can to provide that, especially in remote locations where consistent Wi-Fi access might be a little more challenging. But there's another talk we gave on like using a booster and some other technology to help improve that. All right. So if are there any questions? Anything that we didn't bring up? Andrew, I don't know if there's anything in the Q&A, but now's the time to let us know. We've had family members tone down. Oh yeah, Daphne. Absolutely. So Daphne just stated that, in situations, and it's to protect, and a lot of times it's out of love, that it's hard for them to hear, it's hard for them to communicate. They're trying to also protect the person's pride. So they might just tone it down a little bit, or afraid that it'll result in a consequence for this individual that they worry about. Um, so that's why it is important to have professional interpreters that will hopefully give us the details as we need to hear them to be the most helpful. Anybody else have questions or comments? Well, I hope that if you do, you'll feel comfortable responding. As you know, there's the office hours that are great resources for bringing some of these questions or concerns after we hang up today. If you're like, oh, I wish they would have brought this up, please feel free to email us. Please feel free to also bring it up at the office hours. We will make sure to get information to you as quickly as possible. And as well, thank you for the work that you're doing. I mean, really honestly, I don't know if you're told enough how appreciated you are, but going through all of these trainings and providing this service for the community is just one step towards creating greater equity. And I really do appreciate the work that you're putting in.
Hey Jennifer,
Yes.
so really quick, there's nothing in the Q&A, but there is one question in the chat from Jacob.
Oh, great.
So Jacob asked, do you have recommendations for working with individuals who are deaf, who are also experience a psychotic episode and are too agitated to cooperate with interpretation processes?
Oh, so that's a great question. That might be something like one of those things where you're in the moment and figuring out how to pivot. So whether it's being able to use visual cards to kind of help regulate a little bit more, so we can get people out of that fight or flight and being able to then communicate. So it might just be doing some of that work before we go deeper and further into assessment, giving people the opportunity to get those 6 seconds where their cortisol can kind of lower a little bit more so that we can engage them. Um, those are some strategies. Anybody have other strategies that might help in that moment as well? Can you read that question again one more time for me, Andrew?
Yeah, of course. So do you have recommendations for working with individuals who are deaf and who are also experience a psychotic episode and are too
Mhm.
agitated to cooperate with the interpretation process?
Yeah. And the other thing I can think of, that's when I knew that was the approach with the psychotic episode. So, you know, working with it instead of against it. And so if they are seeing things or hearing things, oftentimes it's better to just not challenge those things, to kind of roll with it, so that they feel safe and connected. And then that might get them to be a little more open. But at some point, if you can't secure safety for that individual, if you're feeling like that everything you're trying to do, and it's escalating and you're not able to, and the interpreter isn't able to sort of help um, communicate things in a way, then obviously, taking that next step in care might be something that needs to happen. But I would like to really, think through additional strategies with people. I think the office hours can also be another space where we're able to address this more fluidly and be able to have some different scenario based discussions, because my guessing is that you might have some specific scenarios in mind. Um, and we can maybe address that a little bit more. And anybody else have ideas, please feel free to jump in. Okay, and we do have a link in there on registering for office hours. So if I've heard people have found those to be very, very helpful because they're county centered. So they're able to sort of bring forward active questions and hear and learn from each other. So really encouraging that. That would be a good time to inquire who's a safe person for them to de-escalate. Absolutely, Nicole, great. So if you're not that safe person because you're a stranger, they're not comfortable, is there somebody there that has the capacity to be able to help them experience calm? Because there may be somebody in that environment that has worked with them before and can help them. Now, if they called because those things were no longer working, then that's one thing. But if they haven't yet, or maybe it's a family member that they don't see very often that just has a really good way and we can video chat that person in, that can be another strategy. That's a very good idea, Nicole. Like using all our resources. um, that's really good. Well, I appreciate everybody's time today. I'm going to give you 5 minutes of your day back. I know that's not a lot of time, but it's something. So I do appreciate all the input. Please let us know if there's any additional questions that we can address. And in the meantime, I hope you have a wonderful rest of your day. Thank you very much.